Hi, everyone. I'm Jen Rubin. I'm from Lurie Children's Hospital here in Chicago, a short trip to here. And I'm going to give, hopefully this won't take the whole time. I know we're running a little bit behind, but I'm going to talk a little bit about leukodystrophies 101 to kind of set the stage for families and explain some of the terminology, the medical terminology. We set up these leukodystrophy centers of excellence across the country to have local and regional care for patients. But the real experts in leukodystrophies are the families and the patients. So while I'm attempting to teach you something, really, you guys know a lot and teach us every day. So it's a fine line between feeling like I'm kind of explaining some terms to you while also knowing that you guys know a lot of this stuff already. So I apologize if it seems too basic. To advance the slide. So I've tried this and I've tried, oh, there we go. Perfect. Okay. It's a little daunting to think this is going to be recorded for years, but I will do my best. So we're going to talk a little bit about what is a leukodystrophy and different types. We're going to talk about how they're diagnosed, how they present, and how they're diagnosed. We're going to talk a little bit about treatments and kind of the different concepts of treatments, and then I'll kind of summarize at the end. So in general, leukodystrophies are genetic disorders affecting the white matter of the central nervous system. And the central nervous system consists of the brain and spinal cord, and they may or may not have peripheral nerve involvement. And we'll talk a little bit more about each of these terms. So leuko means white. So like leukocytes or white blood cells. So leuko means white, and it talks about the white matter. And dystrophy is wasting or degeneration. So for instance, muscular dystrophies are a group of conditions that cause muscle wasting. So leukodystrophy, this is kind of where the term comes from. So the white matter of the brain, let's see. I don't know. Oh, you can see my pointer. Perfect. So the brain consists of gray matter that's on the outside, and then inside is the white matter. And it's white because it's myelinated. And then these are the ventricles or the fluid-filled spaces. So the myelin sheath makes up this white matter. I need to keep touching it or it goes off. There we go. So leukodystrophies result from abnormal production, processing, or development of this myelin or components of the white matter, such as the supporting cells. And some of these supporting cells are the oligodendrocytes and astrocytes and microglia. These are glial cells. So you can see the neuron here, and then the myelin sheath is part of, oops, sorry. It's very sensitive when I touch it. There you go. So I'm going to talk a little bit about peripheral nerves too. So peripheral nerves are the nerves that exit the spinal cord and go out to the muscles and nerves. They send information from the brain and spinal cord to the rest of the body, as well as bringing sensory information back. And peripheral neuropathy is damage to those nerves outside the nervous system. And these, there you go. These are myelinated as well, but their Schwann cells are what myelinate them. So in the central nervous system, it's the oligodendrocytes, and in the peripheral nervous system, it's Schwann cells. I'm not going to be testing you on this later. I'm not sure why we keep losing. There we go. So in 2015, it was Dr. Vanderveer and colleagues decided that it was necessary to have like a formal classification and case definition of leukodystrophies. So I kind of gave you an overview of what leukodystrophies were, but in truth, at that time and still today, the number of funded studies in leukodystrophies is small, likely related to the presumed rarity of these disorders, and the lack of precise classification made kind of studying and incidence even harder to report. So the classification allowed for more clarity and recognition of leukodystrophies and their relevance to public health. So they proposed in this paper that leukodystrophies are a heterogeneous group of disorders with variable clinical manifestations and pathologic mechanisms. So because there isn't a clear age or pathology feature. They needed to look to other features to kind of classify or accept them as leukodystrophies. And like I said, this lack of a precise case definition hampered efforts to kind of study epidemiology. So they had a consensus definition, and I'll show you that. And they took into consideration the involvement of the white matter in the central nervous system. And 30 distinct disorders were defined as leukodystrophies based on this definition. And I'm remiss to report this. So this was in 2015. I suspect there are more disorders now added to this. One of the advantages of this classification system was that it can be used prospectively, so that if new disorders arise, they can be applied to this definition and added as leukodystrophies as well. They also determined that there's a bigger class of genetic leukoencephalopathies. So genetic conditions that affected the white matter of the brain, but that weren't specific leukodystrophies. So they characterized another group of conditions that had white matter involvement, but were not more specifically leukodystrophies. So the case definition that they came up with was that leukodystrophies are inherited, so passed along in the genes, that affect the white matter of the central nervous system with or without peripheral nerve involvement. And that these disorders have in common glial cells, which support the myelin, or the myelin sheath, which surrounds the axons, abnormalities of those. And then, since then, other colleagues have published incidence of about 1 in 4,700 live births is the estimated incidence when you look at all leukodystrophies together. So at the time, and like I said, this may have expanded, these were the 30 leukodystrophies. And there's ones with asterisks that on initial first survey round had 100% consensus. So some of the more classic leukodystrophies like X-linked ALD, metachromatic Krabbe, those on initial pass had 100% consensus. And then some of the others, they kind of worked through the definition. So this is not included in the paper. They did not distinguish between the different types of leukodystrophies, but because I'll be touching on it, I just kind of wanted to mention it. So leukodystrophies fall into two broad categories. There's hypomyelinating, which is absent or diminished myelin production, or dysmyelinating or demyelinating, which is myelin destruction. And you can see some of the more common leukodystrophies that fall in the categories. I will not really be speaking much about specific leukodystrophies in this talk, but you'll see occasionally ones kind of classified. And then they also looked, there were additional genetic conditions that involve the white matter, and they called these genetic leukoencephalopathy. So these are disorders with significant white matter abnormalities, but did not meet specific criteria for inclusion. Some of those were, they had primary neuronal involvement, so the neurons were affected and not the axons, and so it was a different mechanism of action. And then they also excluded conditions in which the prominent systemic manifestations overshadowed the white matter abnormalities. So systemic diseases, maybe like mitochondrial diseases, where it wasn't just the white matter abnormalities. So just to kind of clarify, genetic leukoencephalopathies are a broad umbrella of conditions that are genetic conditions that affect the white matter. Within that, leukodystrophies are a subset. So all leukodystrophies are genetic leukoencephalopathies, but not all leukoencephalopathies are leukodystrophies, if that makes sense. Okay, so we're going to talk a little bit about how these conditions should be recognized and diagnosed. This is helpful information for us to pass along to pediatricians for them to be thinking of when they should be thinking about leukodystrophies. So like I said, they're a large group of diverse conditions. They can present in infancy, childhood, adolescence, or adulthood. Some present quickly following an illness or an injury. Vanishing white matter comes to mind. Others progress very slowly and actually can be mistaken for static conditions like cerebral palsy, unless you kind of take a very long view of the condition and the course. They typically present with motor symptoms versus gray matter diseases, which typically present with seizures. And so when to suspect, like I said, they almost always affect the motor symptoms. Hypomyelinating leukodystrophies can have motor delay, and then leukodystrophies with myelin destruction can have motor regression. And of course, they can overlap, but that's kind of a more general classification. And when we talk about motor symptoms, we talk about clumsiness, spasticity, more frequent falls, toe walking. You can have deterioration after illness. The cerebellum, or the back part of the brain that controls balance and coordination, can also be affected, so people can have ataxia. And then we talked a little bit about peripheral neuropathy. And as the disease progresses, people can have abnormal tone, abnormal movements, increased difficulty walking, trouble with speech or swallowing, problems with vision and hearing, and then decrease in physical and mental development. It's also important to note that leukodystrophies can have other organs involved. So endocrine abnormalities are very common. Eye abnormalities, different leukodystrophies can have characteristic facial features. And so it's important to assess the whole patient, and sometimes those clues can help us diagnose the leukodystrophy or put it in a category. So for diagnostic recommendations, the most critical, I would love to say that as a neurologist, I would love to say that a history and a physical exam is the most important thing, but alas, MRI is probably the most important thing. So CT scan is like a quick image of the brain but doesn't show details. MRI, is, I'm sure you guys know, is critically important. So at birth, babies are not myelinated. So you need a neuroradiologist or a child neurologist who understands the normal myelination pattern so that they can interpret kind of the myelin, if it's normal or abnormal based on the age of the patient. If we see something like delayed myelination, it may be helpful to repeat an MRI scan in at least 6 months to see if it's abnormal or it's just delayed. And then in patients with undiagnosed leukodystrophy, the recommendations are to get a spine MRI at least one time in the course just to see if there's any involvement. So I'm going to go over a little bit of MRI 101. So this is called an axial image. It slices through the brain this way. So basically the patient is laying in the scanner. I always demonstrate this, but like laying in the scanner like this, and you're looking from the feet up. And this is what we call a T2 image, where actually the gray matter on the outside is bright and the white matter is dark. And it's a flare sequence. That's a special type of T2 sequence where the CSF here in the middle is blacked out, is zeroed out. And we do that to accentuate or bring out any abnormalities around the ventricles. So you guys may see reports where it says like T2 flare hyperintensity. It basically is a T2 flare image, and the hyperintensity is the brightness. So this is an unaffected MRI scan. And then you see here on this side, around the ventricles, is this T2 flare hyperintensity, this brightness, and this is the area of abnormal white matter. Typically, leukodystrophies are symmetric, unlike things like multiple sclerosis where you can have multiple lesions. Things that suggest a leukodystrophy is that it's symmetric, it's diffuse, and then the pattern can help us determine the leukodystrophy too, if it's more anterior or the front part of the brain, or it's more posterior like an adrenal leukodystrophy. And then some of the leukodystrophies like X-linked ALD comes to mind. The contrast is helpful. So you take a picture of the brain, you give the dye, and then you repeat the image to see if things light up. So I'm not going to get too much into the weeds with this, but there's kind of classifications or characteristics of MRIs to help discriminate between different leukodystrophies and genetic leukoencephalopathies or conditions that aren't leukodystrophies. It's not uncommon for me to get referred a patient with developmental delay who has abnormal white matter, who actually just had probably an event prior to birth, and they have multifocal kind of areas of abnormality, and so these criteria help distinguish leukodystrophies from other conditions. So some of the imaging characteristics can help us differentiate hypomyelinating versus the dysmyelinating leukodystrophies. If the white matter abnormalities are confluent, that's more suggestive of a leukodystrophy versus kind of multifocal. And then, like I said, if it's confluent, the predominant location. So the front, the back, around the ventricles, these are not 100%. There are leukodystrophies that have multifocal involvement, but these are kind of, and there's lovely MRI diagnostic criteria that that Dr. Vandernap published where it kind of helps differentiate some of these as well. So between the patient's age, their presenting symptoms, the MRI appearance, and their biological sex, because some of these conditions are X-linked, it helps guide us to think of more specific leukodystrophies. And then following the MRI pattern analysis, the standard approach of diagnosis consists mostly of biochemical testing and gene testing. So everyone loves to think of gene testing as like the end-all be-all, and it is for confirmatory testing, but biochemical testing, where we look at like enzyme activity and things like that, is much faster to come back, and so it's very helpful to send those tests too. So this biochemical testing is essential for rapid and reliable diagnosis, particularly if there's kind of clearly defined leukodystrophies. So lysosomal enzymes for things like metachromatic and Krabbe, very long chain fatty acids for X-linked ALD and Zellwegers, and then things like urine organic acids, plasma amino acids can identify other genetic leukoencephalopathies that aren't leukodystrophies. And then if you have, some of those tests like this lysosomal enzyme come back in like less than a week. So if you have a specific enzyme abnormality, you can test for that specific confirmatory gene, and it saves a lot of time and money. If you suspect that they have a leukodystrophy, but we don't know which kind, there's a leukodystrophy genetic panel that tests for the most common leukodystrophies. And then if you want to cast a broader net, it's some of these second generation, like next gen sequencing, like whole exome sequencing. And that casts a broader net, but it takes longer to come back, sometimes to the order of months. So you can see for some of these that have time sensitive treatments, the enzyme testing is the way to go. Other tests that can be useful are, like I said, blood tests to look at other organ involvement. Sometimes spinal fluid analysis is helpful. EEGs to look if there's seizures, eye exams, nerve conduction studies if there's peripheral nerve involvement, and other things like brainstem auditory can look at the hearing, and visual evoked potentials can look at the vision. Not everyone needs all of these things. These are just some tests that the neurologist might use to help diagnose leukodystrophies and assess a patient. So just a word, we're going to have a session this afternoon about undiagnosed leukodystrophies, but for undiagnosed leukodystrophies, we use like a whole exome or whole genome sequencing, and then that genetic testing can be reanalyzed. So what I didn't quite understand about a whole genome or whole exome sequencing is what you put in it is what you get out. So not every single gene is analyzed. They specifically pay attention to what symptoms you put in. So if you put in leukodystrophy, or you put in hypertrophic cardiomyopathy, which is a heart disease, the test is tailored to what you put in it. So if there's new symptoms, it can be helpful to rerun it. Or if there's an updated family history, or there's been some time that passed, that the technology has improved, or more genetic conditions have been reported such that you can reanalyze that sample you already sent and run it again. And then just a plug about the undiagnosed disease network that is patients can refer themselves or doctors can refer. There's information on there about how to apply. And they're particularly interested in genetic conditions. Okay, so just a comment about newborn screening. So the other way leukodystrophies are diagnosed is via newborn screening. So as you know, when babies are a few days old, they undergo special testing for rare and potentially treatable conditions. Actually, it includes blood tests as well as hearing and heart screening. The current leukodystrophies that are on newborn screening are Krabbe disease, metachromatic leukodystrophy, and X-linked adrenal leukodystrophy. The very long-chain fatty acids for adrenal leukodystrophy also diagnose as Zellweger spectrum disorders. The important thing to know about newborn state screens is it varies from state to state. So absolutely what you get tested for in one state differs than what you get tested for in another state. And states need to go through a process. Each disease needs to get added one by one through the legislation. So it's an arduous process. And there is a recommended uniform screening panel, a RUSP, where conditions are recommended universally. X-linked ALD is on that RUSP, but it still doesn't guarantee that states test for it. So just because something is on the RUSP doesn't mean that each individual state tests for it. It's also important to know when these tests were, for neurologists, it's important to know when these tests were started in your state. For example, in Illinois, X-linked adrenal leukodystrophy was just added in 2019. So if a school-age child presents with developmental regression and has an MRI suggestive of ALD, they were missed and they were too old to have been screened in newborn screening. So it's important to not assume that these conditions were all caught, because a lot of these kids some of these kids who are presenting are too old to have been tested when they were born. Okay, so we'll talk a little bit about just kind of the concept of treatments. So just to kind of clarify, there's lots of supportive treatment, even in the absence of curative therapies. And I think a great model of that is cystic fibrosis. So many, many years ago, cystic fibrosis community decided to take a consensus approach and treatment guidelines to, for aggressive pulmonary treatment, aggressive use of antibiotics, excellent use of nutrition, and without any curative disease-directed therapies, they increase the life expectancy of children with cystic fibrosis every year by about a year. So actually, recently, cystic fibrosis was removed from the list of conditions that qualify for Make-A-Wish, which is just incredible. So even in the absence of curative therapies, there's lots of supportive treatments we can do for patients and families. And Dr. Keller and myself were thanks to Hunter's Hope, wrote this paper about kind of approaches to caring for children with leukodystrophies. I'm going to summarize the recommendations of the paper just to say that, and I think Dr. Keller is going to talk about this, multidisciplinary care. So in all stages of leukodystrophy, neurologic care can be optimized. It requires a multidisciplinary approach and attention to the stage of severity. So kids or adults with pre-symptomatic disease or disease that hasn't started or hasn't had any disease manifestations have very different needs than kids whose disease is in a different stage. Palliative care involvement early in the disease course can help families immensely. So just to kind of put a plug for one of my favorite group of people in the world is my palliative care colleagues. Palliative care is not synonymous with hospice care. Hospice is a subset of palliative care that deals with end-of-life issues, but palliative care is, I'm just going to hop on my soapbox for a moment, it's specialized medical care for people living with serious illness. So people with sickle cell disease or any kind of chronic disease that is serious, it focuses on providing relief from symptoms and stress of the illness. The goal is to improve the quality of life for the child and the family. And it's appropriate at any age, any stage of the illness, and it absolutely can be provided along with curative therapies. They're not mutually exclusive. Okay, so back to our publication. So we talked about the main neurologic symptoms that affect kids with leukodystrophy: sleep disturbance, pain, seizures, and then cognitive difficulties. They should be assessed at each visit. And then we talked a little bit about, in this paper, we go into more detail about the treatments for each of these things. So sleep disturbances, good sleep hygiene. If you need medications for other symptoms that are sedating, you could use that to your advantage to help with sleep. And then we talked about pain, and sometimes children with more progressed disease can have a higher incidence of pain, and to kind of assess for that and look for that. And we also talked about seizures. They can be more common in some leukodystrophies. And if you have an earlier onset leukodystrophy, it's more likely to be associated with seizures. And then we talked about continuing to assess kids' development. If there's regression or loss of skills, we should look for other potentially contributing causes, like let's look at their nutrition, let's look at seizure burden, and not necessarily assume it's from disease progression. And then children with hearing and vision impairment should be evaluated for adaptive devices or other means of communication. So we're going to talk a little bit about curative therapies. So currently, the only curative therapy for leukodystrophies, and I'm noticing we're kind of running a little bit short on time, so I'll kind of speed this along, but is a hematopoietic stem cell transplant. I think we use the term stem cell transplant a lot, and I don't think, unless a family's been through it, doctors necessarily explain what it is. So I'm going to take the opportunity to briefly explain what it is. So there's allogenic stem cells, where you get the stem cells from someone else, and there's an autologous stem cell transplant where they take your own stem cells and change them and give them back to you. These are allogenic stem cells. So basically the donor, they collect stem cells from the donor. The donor can also be a cord blood, and they process and preserve them. And then the patient, who's going to be the recipient of the stem cells, in order for the stem cells to be accepted and engrafted, you have to wipe out the bone marrow of the recipient so that they don't attack the stem cells. So these patients get high-dose chemotherapy. Sometimes there's modified protocols where it's not as myeloablative. It doesn't knock out the bone marrow as much as if you have something like cancer, but it's still kind of a big process. So they get chemotherapy in order to knock out their own bone marrow, and then they get an infusion of stem cells, which is actually quite anticlimactic. It's just a little bag that's hanging that you get the stem cells. And then it takes weeks to months for those stem cells to engraft. And the hope is that the stem cells are incorporated into the patient's own body, that they get to where they need to go, and that they produce the enzyme that's missing in the patient. So these are only effective for a subset of leukodystrophies, mostly ALD, MLD, and Krabbe disease, and only if you're pre-symptomatic or very early symptomatic. Stem cell transplants put the body through quite a bit of stress, so it sometimes can precipitate progression of the disease. They take a while to work, and they don't reverse the injury that's already there. So that's why the ideal candidates for stem cell transplants are very early or before their disease is started. And you are going to hear about some of these other things, so I won't go into too much detail, but kind of in clinical trials are gene therapies. So basically, via various vectors, we try to give the gene that's missing. One of them for X-linked ALD is the autologous stem cell transplant. So basically, they take the patient's own stem cells out, transfect them, or kind of put this lentiviral delivery, and then give them their own cells back that have this new gene that works. Another treatment is enzyme replacement therapy. So if you're missing an enzyme, you can replace it. They have some approved therapies for conditions with white matter involvement, like Gaucher and Fabry, but there is not yet any approved therapy, enzyme replacement therapy for leukodystrophies. The main problem with enzyme replacement therapies, there's a couple. One is that it needs to get to where it needs to go. So these need to cross the blood-brain barrier and get into the brain. The other problem is that they don't last forever. Unlike a gene therapy, you need to keep giving enzyme replacement. It's replacing it and your body breaks it down. And the third problem is that your body can produce antibodies against these. So sometimes over time, people produce antibodies to them. And then there are other kind of exciting new therapies in the works for various leukodystrophies. And this is a great resource for families. If you want to know what clinical trials or what studies are open for yourself or your child or a patient, this is a resource. I think I'm stepping on it. This is a great resource to look for what studies are open and what studies are ongoing. Oh, good timing. So in general, leukodystrophies or disorders are inherited disorders affecting the white matter of the central nervous system. Individually, they're rare, but collectively, they're common and demand attention and research support. Not to say that the individual leukodystrophies don't also demand attention and research support, but putting them together allows increased recognition of them. They should be suspected in any infant or child with motor regression or kind of arrest of development, especially with motor symptoms like tightness or spasticity and unsteadiness. The diagnostic evaluation is an MRI brain with enzyme or genetic testing. Curative therapy can be stem cell transplant, and several therapies are in the clinical trial process. And symptomatic and supportive therapies are critically important, as is supporting families. Okay, so that was a lot of information. What questions do you guys have? I think we have a time for a few, or none if no one has any. Hello?
Anyone have questions? I can bring the mic around. Questions? Let's see. I want to say thank you because this is a lot of information in a small package, and my daughter happened to have an excellent neurologist who knew leukodystrophies very well. But I think had she had another neurologist, she might have taken even longer just for someone to say she probably has a leukodystrophy. Am I too close to you? So I think this would be a great presentation to share with even a pediatrician or neurologist, just to educate them. And I know a lot of people in here are diagnosed, so it doesn't help diagnose your child, but it helps educate your practitioners and clinicians.
Yeah, my non-medical husband learned a lot, more than he had maybe hoped about leukodystrophies when he was listening to this presentation. Real quick, there's a question in the chat about CADASIL as a leukodystrophy, and in that paper, it was classified as a genetic leukoencephalopathy, but not a leukodystrophy. And I think it has to do with the mechanism and what it mostly involves, and some other things that are more complicated than I can explain. But it's in that paper. CADASIL is, and some of these things that, I see kids with genetic leukoencephalopathies in my clinic as well, because they too benefit from multidisciplinary involvement from myself in genetics and palliative care. So I think these definitions are helpful, but certainly not rigid enough that we can't apply some of the things we use in leukodystrophy for patients with other genetic conditions affecting the white matter. Oh, and I also think trichothiodystrophy is not on that list. Yeah, but like I said, that's from 2015, so some of these might have been prospectively. That was the purpose of case definitions, is that prospectively disorders could be added. Let's see if I can go back to the page with the 30 leukodystrophies. I did not. Okay, did someone else have a question in the meantime? Yeah.
About 5 years ago, my son had his first MRI and they found what were called heterotopias, but the neurologist didn't pursue what the cause of the heterotopias were, and we didn't understand and we didn't know enough to ask and try to get to the bottom of things. Well, as it turned out, he has CTX, cerebro-tendinous xanthomatosis, and I'm wondering, how do you get the neurologist to go deeper and, try to pull things together? Because we could have had a diagnosis maybe 5 years ago instead of, 5 months ago.
Yeah, I think that, so the question was, in conditions where the MRI may show atypical features, so heterotopia or congenital brain malformations, or where the brain is misformed, or heterotopia means there's areas that are in a different place, so gray matter that might be within the white matter. I think, I actually don't know the answer to this, but a lot of kids with epilepsy and a lot of kids with a suspected genetic component get a epilepsy panel, a genetic testing for epilepsy. So I actually wonder if we need to make sure that some of these leukodystrophies are on that panel. So most of the conditions on that panel are mitochondrial diseases or gray matter diseases like NCL, but I wonder if we need to make sure some of these like CTX or Alexander, some of the ones that more commonly present with seizures, are on that panel, because that Invitae panel for epilepsy is pretty commonly thought of by neurologists and epilepsy docs. So that might be one relatively easy way to get those to be accidentally thought of more often if they are sending a panel for genetic and it happens to be on it. And somebody might know if some of those, I bet some of them are on it, but I bet not all of them.
Any other questions?
And this list, somebody in the chat asked where this list was. This is in, if you just Google Vanderveer's 2015 leukodystrophy. The problem with a lot of papers is that, and this is a problem with misinformation, a lot of medical papers are under a paywall. And trust me, it is not us that's getting paid. We do these papers for free, and in our time, in our academic time, and then the journals are making a ton of money off our efforts. So, so sometimes like this full article might be difficult to find just on the internet without having an academic institution access to them. Yes. Oh, there's.
And on ulf.org, there's
perfect.
there's a list of leukodystrophies too. Back here. Did someone have a question?
So my husband passed away 2 years from adrenal leukodystrophy. My grandson was diagnosed with adrenal leukodystrophy. So he just, his first CT scan he had, or MRI was done, and it came back normal, and that was like 6 months ago. So he just had one recently done Friday, and they called and said that they were showing signs of something, but they were saying that he probably has the mumps. And he's vaccinated. He doesn't have the mumps. So it might be something that they're not that they don't know, because he does have adrenal leukodystrophy. So I don't know, should I tell my daughter, like, get him, have someone, I wanted her to come, but she's like, she's not ready to
Yeah.
deal with it. And I don't know if it's signs that
Would
his
you-
adrenal, because like my husband, he was fine. He worked 52 years undiagnosed anything. All of a sudden he got sick, and all of a sudden it was just done for him.
Can you tell me If you don't mind telling me how old the child is?
He's 3. He turned 3 in December.
So there actually was a lovely poster out there looking at the incidence of what we call like incidental or accidental findings in patients with X-linked adrenal leukodystrophy. So boys with X-linked adrenal leukodystrophy, the important thing is to try to catch the disease before they have any symptoms. So the published guidelines are to do an MRI scan every 6 months between about 3 to 12 years of age. And so, and the first MRI we typically do between 1 to 2 years of age, basically just to look to make sure nothing else is going on, so that when we do an MRI for X-linked adrenal leukodystrophy, if we see anything, we can say like, is this related or unrelated? So that's a long explanation to clarify your question. So the poster out there was saying that it is not rare to find other things on MRI scan that are not related to X-linked ALD, and it causes a lot of anxiety and confusion in the families. So it may be that if he's 3, he's a little young to already have changes on the MRI based on X-linked ALD, and they need to look at the pattern and see where it is. So it may not be related. Now, what it is, I don't know the answer to that, and I think you need to talk to the neurologist so they can review it. I can't really comment about like what else it might be, but yes, our MRI scans are really good, and they're just really detailed, and sometimes we see stuff that we don't need to worry about, but that we literally just saw it because we did it.
I just don't want to be like him going through his whole life and all of a sudden
Yeah.
it just pops up.
Oh, these conditions are really hard. And, we have the advantage of testing family members or testing people in newborn screen, which is lovely because it provides us the opportunity to catch things before they start. But it also creates a lot of anxiety and a lot of worry in families. So I'm really sorry. It's really hard.
Does anybody have another question? Oh, we'll have time for one more. Can you raise your hand, whoever had a question? Okay, thanks.
And then I'm going to turn it over to Dr. Keller. So one more question? Yeah.
Hi. We have a 35-year-old daughter with leukodystrophy that's never been treated, and we've been trying for years now to find a doctor here in Chicago to treat her, but because she's an adult, they will not take her. What do we do?
Yes. So, yes, it is a challenge. So there is a critical shortage of geneticists and pediatric neurologies across the country, and the wait time is about 4 to 6 months. And so as a general practice, most pediatric centers only take care of pediatric patients. And there's a lot of reasons for that. They can't admit them to the adults to the hospital. There's reimbursement and payment issues. But the problem is there's a lot more pediatric neurologists that feel comfortable with these conditions than adult neurologists. So we are trying in Chicago and in other centers to get our adult colleagues on board and to learn more about these leukodystrophies. I think that any general neurologist should be able to take care of a patient with these conditions, with seizures, with abnormalities of tone, with sleep issues. These are problems. I think people are daunted or intimidated by the idea of a leukodystrophy, but these conditions have things in common with other conditions that neurologists already take care of. So I think that adult neurologists should be able to manage symptoms and diagnose these conditions as well. It is tough. They also are, I don't know how to say this, but they're very, very I think there is more room in pediatrics. Pediatrics is not a money-making endeavor. So I think there is more ability in pediatrics and more philanthropic support to spend more time with patients, to have child life, to have our social worker who's here today in the room with me. I think it is harder for our adult colleagues to be able to provide the care that patients need under their financial strains, which is no excuse for anyone, but it's the reality of medicine. Yeah. That did not help or answer your question, I don't think.
Okay. Well, thank you, Dr. Rubin, and thank you, everybody, for participating and joining her session.